personally or in your EDs as a result of a participation in the ED Stop Suicide QI Collaborative, as well as improvements that have already been demonstrated in the ED. And we will be hearing about that from Dr. Susan Duffy. So these results that Dr. Duffy is going to be presenting will be ones that you have shared with us through the post-collaborative session evaluation survey. The beginning and ends of this session will be recorded, so excluding our ED site team presentations, those will not be recorded, but the beginning and ends of the session will be, and they will be posted to the EIIC website as always. Lastly, the direct links for nursing and social worker CE and CEU credits will be given out at the end. We can go on to the next slide, please. So here are the formal objectives for today's session. Thank you all for putting your first and last names into the chat. And we can move on to the next slide, and I will pass it over to Dr. Kate Remick.
Great. Thanks so much, Eleni, and welcome everyone. It's great to have you all here for this very last session of the ED Stop Suicide Collaborative. You all have done really tremendous work during the whole course of this collaborative. We appreciate every effort that you've made and sticking with us to this juncture. Really just wanted to share some high-level overview. Some of these slides you've seen before as we were launching this collaborative, and it might have felt a little bit overwhelming or like a lot of information when we first shared them with you. But the reason that we have these quality improvement collaboratives is that we're able to centralize resources in order to support frontline healthcare teams in implementing evidence-based practice strategies and/or new processes and efforts. All of our quality improvement collaboratives are founded on these 7 core principles that are listed here, from evidence-informed content, QI methodology, project management, IT infrastructure, data management, analytics, and research. And all of you now are very familiar with the Plan, Do, Study, Act cycles that are accelerated through some of our learning sessions, many where you all have shared your progress with each other, learned from each other, and then intermittent action periods in between those sessions. What we hope that you found during these quality improvement collaboratives is that we're all in this together. And I think these are really a nice forum to build trust across institutions, that regardless of your resources or where you're located, regardless of your training, that we're all here trying to do the right thing for children. And we hope that the incentives relative to maintenance of certification credits or continuing education credits have been beneficial in helping you to really engage with this work. Next slide, please. What we use within our quality improvement collaboratives is the Institute for Healthcare Improvement's Breakthrough Series model. This is perhaps the most well-known model for quality improvement collaboratives, and so much of their work is really focused on hospital-based care and clinical care processes that are happening within the walls of a hospital or acute care institution. And over the course of this collaborative, we followed this model really every step of the way. Even before you all began this collaborative, we had a group of wonderful subject matter experts and/or faculty who really helped us in developing the content, the framework, the change strategies that were being used for the ED Stop Suicide Collaborative. You all, of course, came on board with this collaborative not quite a year ago now, and then have engaged through a number of Plan, Do, Study, Act cycles. Some quality improvement collaboratives are much more structured in that everyone's moving through cycles at the exact same time or cadence. But because many of our collaboratives have diverse participants, you all know that you've worked at your own pace within the infrastructure that you have in place and based on the support that you have to really drive improvement strategies over time. Next slide, please. What I also hope you all know is that the whole reason why we do quality improvement collaboratives is that they really do lead to rapid transformation. And Ballas and Boren have shown that if you look at research publications and the time that they come into print, it takes an average of about 17 to 23 years before the field actually begins to place that in practice, to really begin to uptake that as the new norm. But within our quality improvement collaboratives, what we are trying to do is more rapidly transform our healthcare system by driving that evidence into practice over a 3 to 5 year time period. Next slide, please. This is a really nice quote. This was from some work that was done actually globally, but I think it's nice because it speaks to the fact that we're not trying to change the resources or the environment in which you work. We're not trying to say that everyone needs to be a children's hospital or the most robust system. But what quality teaches you is how to use the resources that exist. They don't necessarily provide new resources, but it's ways of really beginning to optimize those that we have around us. Next slide, please. So just some observations that I have had from quality improvement collaboratives, this one in particular, but many over the years, is that hopefully you realize that QI collaboratives are indeed founded in evidence-based practice, and we're grateful to our subject matter experts who were part of this in guiding much of that work. Hopefully you felt that this has been a really supportive environment, and you've come to realize that many other colleagues are facing the same challenges. I think all of us find it really motivational hearing from other peers and or experts in the field about the work that's being done, the barriers they've overcome. And hopefully you've been able to take away some of those best practices and adopt them into your own environment. What is probably the most important piece is that we're actually impacting outcomes for children. You've heard so much about the mental health crisis that's impacting youth in our country. And I know because of the work that you've done here, you have made a significant impact on the children in your community. We hope to continue to allow you all and support you all in working collaboratively across networks. And hopefully because of your participation in this collaborative, you've really demonstrated yourself to be a leader within your own institution and or organization. Next slide, please. The main reason we're all here and why we within the EMSC program, the EMS for Children program, do this work is that we're really trying to improve outcomes for children. And this is a manuscript, if you're not familiar with, that was published by Craig Newgard and colleagues. And what he showed is that if children, critically ill or injured children, come to emergency departments that are pediatric ready, that is associated with decreased mortality, 60% for injured children, 76% decreased odds of death for ill children. And that's hugely significant, especially since most children actually survive acute emergencies. And more importantly, because of the work that you've done here within this Quality Improvement Collaborative, one thing I do want to point out is that if you continue to engage in quality improvement, you begin to uncover some of the deficiencies that exist within your own clinical care processes or institution. And that's associated with an average 26-point increase in overall readiness. And that means you can shift from the lowest quartile to the highest quartile of readiness and really impact lives for children and their families. Next slide, please. The reason that we focus on this so much is that most children are seen in EDs that are not pediatric ready. Most EDs see fewer than 15 children per day, as you all know, but collectively that's where children are seen. And so the idea behind quality, and I love this quote from Henry Ford, is that quality means that we're doing it right when no one is looking. And unfortunately, I think in most EDs, we're not always looking at what's happening in terms of the pediatric population. So this is a really nice way to have a window of insight into what's happening for the care of children. Next slide, please. So lastly, just as a reminder, the EMSC Innovation Improvement Center is a national resource center, virtual center. We provide hopefully a lot of resources related to evidence-based practice. We work collaboratively with multiple different national organizations and professional societies and families. And we really leverage quality improvement methodology as a foundation for our work. If at any point you decide you really enjoyed this Quality Improvement Collaborative and you're interested in exploring more, we have lots of quality improvement collaboratives that are ongoing. Some of you are probably participating in the Pediatric Readiness Quality Collaborative, but you'll see the website link at the bottom there, and you're welcome to explore, and we encourage you to join us in the future. So with that, I'm going to turn it back to Lenny. Thank you.
Thank you so much, Kate, for that overview on the true impact of QI collaboratives. So now we are going to be moving into our ED site presentations. So thank you so much to all of the following teams that were willing to share their QI project work with us today. So first, we are going to be hearing from Toma Health. So we can move on to the next slide.
And speak on behalf of all of the facilitators of this collaborative about how impressive this group has been. The wanting to be a part of this group and a recognition of how important this group of patients, and really a high risk group of patients that we were not prepared for, and why it's such an important part of readiness. The readiness to care for children with mental health problems just fits in right along with the readiness to care for children who need resuscitation and every other aspect of care. So really, congratulations. It's also the other really impressive thing is that the variability of resources is really profound, and how the various teams have worked around with the resources that they've had. Can I have the next slide? When we look at when we look at the survey that was many of you responded to about what were the positive changes and how what the improvements you had, it really fell into a couple of categories. And I'd say that many teams really leveraged the models that have been successful in other emergency departments or systems and recognize the need for systematic ED processes to really improve the delivery of care. And that included by creating clinical pathways. I mean, we are hearing it today for suicide screening and assessment, trying universal screening versus targeted screening, developing procedures for triage, safety assessment, monitoring, really those processes, putting them in place, because for many EDs, they have not existed. And then talking about the accountability of who's responsible for screening, who's responsible for the assessment and for the consultation. Those are really a lot of barriers that emergency departments face and have wanted to address. And then the efforts to form specialized and train teams, I think that's very, very important. We can't care for this population of patients without specific training. And it's training that goes into a new paradigm to really provide trauma-informed and developmentally appropriate safe care for kids. And then the next step is really, how do we assess that? Are we doing a good job? Are we doing the right thing? What are the metrics to test changes and improve ongoing quality? Next one. The other group, the next sort of bucket that the positive changes fell into was really creating systems to plan safe discharge. We know that the majority of children with suicidal ideation will be discharged and will go home. And we also know there are a high-risk group of patients that completed suicide often occurs within a short period of time after an ED visit. So in preparation for this, we really, groups really focused on this to facilitate follow-up and mitigate risk. This is really something very, very important that we can do in EDs. And that occurred by developing suicide prevention resource packages. We heard a lot of it today. Implementing discharge care coordination for patients at risk and improving linkages to follow-up. Empiric evidence really shows that this makes a difference. Developing discharge bundles and safety planning toolkits. Talking about educating staff to provide lethal means restriction counseling, providing gun locks, medication bags, improving communication with mental health assessment teams that may be via telehealth to really facilitate and reinforce safe discharge and make sure everybody's on the same page. Implementing systems, I heard today, callbacks and follow-up calls to improve linkage to follow-up. And then really improve our processes and communication around transfers, admissions, so that we can really have a safe flow and a high quality that really is patient-centered. Next one. And then the third bucket that our improvements went into had to do with improving the quality of experience, of ED experiences for patients and families. Talk about not being prepared in a chaotic emergency department environment to have children stay for long periods of time and families. Where do they stay? How do we adapt our EDs and make them developmentally appropriate and really mitigate risk and improve the quality of care? And the really interesting interventions that have occurred by this group have included staff education to provide trauma-informed and developmentally appropriate care to children with mental health issues. There are some that have focused on children with autism, adapt our environments to decrease stimulation, to be family friendly, to incorporate distractions. Even some EDs have brought in yoga and relaxation as diversions. I think we could all use yoga. And then incorporating mental health and family support staff, specialized staff into ED care, implementing customized care plans, particularly for those kids and for those children who have to have prolonged stays. And then train our staff and form teams to really manage agitation through de-escalation, developmentally appropriate, and really focus on how to prevent escalation to begin with. Those are all the incredible work that groups reported from this collaborative. So impressive, and congratulations to everybody. I'm going to turn it back over to you, Lynn.
Thank you so much, Sue, for going over those post-collaborative session evaluation results that you all have shared with us. And it was just amazing seeing the positive changes through that survey and then also through our presentations today, and everything in between. So thank you for going over that for us, Sue. We can go to the next slide. So there is a new collaborative that is launching. We just wanted to make everybody aware of. The Pediatric Mental Health Technical Access Programs are launching a collaborative with its first collaborative session on February 22nd, 2024, with the intent for participants to learn more about PMHCA programs and how they can offer assistance to your EDs. The current states that have a PMHCA program are listed on this slide, but additional programs in other states and U.S. territories are expected to be created as well. Under the Partners tab on the EIIC website, you can learn more about the EIIC's work with PMHCAs, as well as find the registration link for this collaborative learning session in February, which will also be added to the chat right now. Okay, see, it was added. And then you may also reach out to Anna Goldman with any further questions you have about this collaborative session, and she can also add her email to the chat right now too, so you're able to reach her. Next slide, please. So just because ED Stop is ending doesn't mean that your QI projects or PDSA cycles have to end. Now you are all equipped with the tools to be able to create new SMART aims, improve, continue on with, or create new PDSA cycles and QI projects. I wanted to let everyone know that the intervention bundle guides for suicide screening, mental health assessment, ED-based interventions, and discharge and safety planning will all remain on the ED Stop webpage if you ever want to refer back to those intervention bundle guides and maybe starting another QI endeavor in a different bundle. Additionally, all of our fireside chats and collaborative sessions will remain on the ED Stop webpage as well. And then lastly, please fill out the ED Stop Suicide QI Collaborative post collaborative final evaluation survey if you haven't already. Your feedback is extremely important to us regarding your experience throughout this collaborative, and we are requesting that each participant fills this out. We want to hear from you about your projects and how we can improve in the future with future collaboratives. Next slide, please. So now, nurses, if you joined late and haven't already, please put your first and last name into the chat. And then you may use this QR code or direct link being put into the chat to fill out the form to receive CE. Thank you, Casey, for putting that into the chat.
Eleni, if I can just take 30 seconds just to say again, thank you so much to everybody who participated, and really congratulations on an amazing work by everybody. you are proving that no matter what kind of setting you are in, there's always opportunities to make an improvement, and you guys have done an amazing job. I just wanted to also say, just because the collaborative is coming to a close doesn't mean we are going away. We are going to continue to remain available to you. Please feel free to reach out. And Eleni, if it's possible, we can give a list of all of our facilitators' email addresses or contact information so that people can reach out with any questions. We want you to continue to use this momentum to continue to make improvements. So please feel free to consider us part of your team moving forward, and we would love to continue working with you. Thanks.
Absolutely. Thank you, Mo, for that. We definitely all will still be available to all of you. And going forward, Mo, we can figure out how we want to get our facilitators' contact information available to everybody, and anything else anybody might need in the future. So here is the social work slide. So you may use the link in the chat or use the QR code to access the session evaluation to get your CEUs. And then that is all we have for you today. I sincerely hope that everyone was able to get everything that they wanted to get out of this collaborative. Thank you so much for all of you for going the extra mile to improve care for children and adolescents that present with mental and behavioral health concerns. If you have any more questions, we'll hang around here. Sue and Mo put their emails in the chat. So did Dr. Remick. If you have any more questions, we'll hang around here for a few more minutes. You can always email me, email anyone a part of our team, and we really appreciate all the work that everyone has done. So thank you so much.